Hello, 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 AMCI YouTube course for self-studiers. How are you? I'm Mrs. J, one of the curriculum developers here at AMCI. Welcome to week 11. Yes, musculoskeletal and respiratory systems are up next. This is where we do deep dives into fracture treatments, wound explorations, or when we get to respiratory, we'll be coding scopies, endoscopies, etc. All right. Before we go any further, let's say hello to the team. The Dream Team. These are the brilliant minds behind these lessons. The answers in the chat and the forensic level instruction that helps you rise to certification readiness. Yes, coders. Say hello to the AMCI instructional team. And let's not forget our interns. They have the blue badges. They are amazing and they are the rising stars who are walking the same path that you are. Yes. Many of them, as I've said before, are certified, but many of them want to become dual certified. So they're looking to get that CCS as well. So they are striving towards excellence. Yes, they want to be accurate, certified, ethical, forensic. Yeah, and you will too. So please say hello to them. They are the heartbeat of AMCI. Now, I've got a disclaimer. Yes, if you are not familiar with CPT coders, visit our Are You New to Medical Coding playlist. So that's the name of the playlist. And we've got two parts one and two for CPT coding. Go ahead and check it out before you go any further because this might be a little deep. Yes. And speak about deep. What is going on at AMCI? We've got the AMCI Friday night live sessions on Discord. Yes, amazing. We are currently doing Jeopardy, Hangman, and right now that Wheel of Fortune is fun because people can play on their own teams. We can't play with the biggest crowds, but right now, while the crowds are small, you should get in there. It is fun. Also in Discord, our I'm Tap course, that's interactive medical terminology and anatomy and physiology. You can attend every Wednesday, but you've got to be a member of our YouTube group, right? And many people have been saying, hey, I can't get in. We hear you. We know that that link often stops working. We don't know why. We're in touch with Discord. We want to know what's going on. But right now, we've made an effort to update that Discord link from your syllabus. So if you go to your syllabus, click on the Discord link, it should be good. All right, so if you want to know how to join our Discord from your syllabus, these are the instructions. Number one, you've got to first become a YouTube member. Number two, after you become a member, you have to come back and click on this link. This link is good. Right now it is. Also, after you join Discord, find your name and right next to the name, well, not right next to your name, but right here where you see this cogwheel, click on it. This will enable you to connect your YouTube channel with your Discord. So click on it, click connections, then you'll see this menu at number 5, locate YouTube. Click on YouTube, follow the prompts, and you should be in. If you still need assistance, there is a video for you to watch. The link is on your syllabus. Let me get rid of this little prompter. Now, let's move on and discuss the books for the remainder of this instruction. Right now, we're in the second part. We're talking about CPT coding, and you guessed it, CPT 2025 is the recommended book. Also, you'll need your 2025 step by step, your MCG, and your HCPCS level 2. But for this discussion, we will be using your CPT and your MCG manual. And don't forget, keep this going. Tell everybody about this free YouTube course. And I want to send a thank you to all of you that have shared this information. Quite a few of you are telling people. We know because they're telling us. They're saying our colleague at work sent us here, a relative, etc. And to those people, if we haven't told you before, I want to let you know that we hear you and thank you. And for those of you that haven't told anyone, this is your gold. It's not going to always be here if people aren't using it. So share, share, share. And in advance, I want to say thank you. Now, let's go ahead and read the copyright. CPT is copyright of 2025 AMA. All rights are reserved. AMCI trademarks, keyword concept FTR Chun AMCI Fab 7, AMCI ICD-10 CM Flip Tap, and MCG are registered trademarks of AMCI. CPC, CRC, COC, CPMA, CPB, CPM, CPPM, CPCO are owned by AAPC, and CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials. And I want to say this before I move on. Number one, we're going to review the musculoskeletal system. Number two, respiratory system. Number three, we're going to give you a glimpse of the 2025 MCG musculoskeletal section. Four, we will complete practice exercises. And five, hopefully, we'll bring you one step closer to CPT coding mastery. First up, the musculoskeletal system code series, CPT code series 20,000. Now let's begin with a little bit of AMP of the musculoskeletal system. And if you didn't know, the A in AMP is for anatomy. And anatomy is pretty much the structure of the body. And the P is for physiology. Physiology speaks to the function of the body. Now, very briefly, I want to give you some information about the AMP of the musculoskeletal system. Oh, by the way, these images are from KenHub. So if you want to check them out, they are KenHub is amazing. Go to www.kenhub.com. Now, here are some facts about bones and muscles. And if you didn't know, the bones pretty much are the skeletal system, and there are 206 bones in the body. And there are four types of bones. You have long bones, short bones, flat bones, and irregular bones. And some examples of long bones are, they include the femur, tibia, fibula, and also the humerus, radius, and ulna. So pretty much the arms and the legs. Your short bone examples are your wrist bones and your ankle bones. Flat bone examples are your skull bones, the scapulae or scapula, your sternum. Let's pretend like the patient is facing forward, but this is actually the back of the patient, and the ribs. Also, irregular bones. Some examples are the vertebrae, the sacrum, and some facial bones. Now, when we talk about muscles, there are more. There are over 600 muscles in the body. And there are three types of muscles. You have skeletal muscles, smooth muscles, and cardiac muscles. Skeletal muscle examples include your biceps, triceps, and quadriceps. Your smooth muscles include the intestines. Yeah, that's a muscle. If it has to push out the contents of your stomach, yeah, it takes a muscle. Blood vessels and airways are also vessels. And also the cardiac muscle. Some examples include the rapid transmission of electrical signals through the heart. Your heart is one big muscle. So these are pretty much the basics of the anatomy of the musculoskeletal system. Now, the physiology of the musculoskeletal system, your bones, your skeleton, they pretty much support the body and gives it shape. The bones also protect your vital organs. Indeed, look at that rib cage. What's in your rib cage? Your heart and your lungs. Indeed. Bones also support movement. It allows you to run, walk, and stand tall. Bones also store minerals such as calcium, phosphorus, and magnesium. Promotes cell protection in the marrow and energy storage, the yellow marrow. Now, muscles, they support movement, just like bones. Also, the maintenance of body posture and position. So that's why it's important as you get older to lift weights and to improve the muscle function. Also, muscles offer protection to the body, such as heat and natural shock absorbers. Muscles also promotes circulation, the only tissue that has the ability to contract. Yeah, so muscles do that. Muscles also aid in digestion, breathing, and communication, body communication. And don't forget sphincter. I can't say sphincter control. I know something is solid there. Sphincter control. All right, so these are the physiology basics about your bones and muscles. Hopefully that gives you a little insight. Now, let's move on and let's talk about the MCG manual and how it will help us when coding for CPT, respiratory and musculoskeletal. All right. So the this is the 2025 MCG manual. Many of you have 2024, and pretty much we're going to use this manual to review what we call FTRs. FTRs. These are facts to remember. In other words, these are guidelines that you need to remember. So we encourage you to document these guidelines, study these guidelines. Now you're going to document them at the bottom of the pages where the codes live. So if you're coding for, let's say, wound exploration, all of the pertinent guidelines should be at the bottom of the page of the wound exploration codes. Now, some people might say, well, why would we take the guideline that comes from the CPT and then put it back in? Because you will see that these guidelines often aren't easy to decipher, and AMCI pretty much has taken the guidelines and processed those guidelines and made them decipherable for you. So many of you don't need us to do that. So if you don't need us to do that, you don't need this MCG manual. You do not, and I don't encourage you to get it if you don't need it. But many people do need it. They like it. They like the simplicity of how we process those guidelines for you. Um, And not only do we apply specific coding guidelines, we also apply basic guidelines when necessary. All right, so the MCG enables you to study the guidelines more efficiently, cutting out all the fluff, and we've done all the work for you. That's pretty much it. Now, let's take a look at the FTRs for musculoskeletal system. All right, so from the perspective of the digital book, this is the table of contents on the left, and I'm just going to locate my musculoskeletal system. And after I click on it, to the right, the FTRs should appear, or you might have to go down one extra page, and here you are. So pretty much here are the instructions for using the FTRs, or facts to remember pages. Refer to the Facts to the Remember guidelines below for important instructions on how to correctly code specific procedures. FTRs are listed at the bottom of the corresponding code page to ensure quick access. So in other words, you have to place your FTR at the bottom of the page of the corresponding codes. Use these guidelines to apply codes accurately and efficiently as you work through the chapters of the MCG manual. Okay, so let's go ahead and review.
Let's look at types of fractures. Pretty much open and closed is what we're really paying attention to. And remember, if it's a closed fracture, the tissue is not exposed. An open fracture, the tissue is exposed. It can be blood, it can be bone, it could be cartilage. If it's tissue and it's exposed, then it's an open fracture. My son had an open fracture that did not bleed. He slid really hard and all you can see was white. So it was considered open because you could see the tissue and he had to have it sutured back into place. Just thought I would let you know that. So anytime you see the tissue, it's open. When you don't, it's closed. Now let's talk about these treatments. You have open treatment. Open treatment means that the doctor had to open the surgical site. The doctor opened it to treat the fracture. And in this operation right here, you see a lot of instrumentation. So the doctor had to open the surgical site to apply the instrumentation. The doctor inserted screws, pins. Wow, it's pretty extensive, right? And sometimes this instrumentation can sit outside of the body. But as long as you know whether or not the doctor incised the patient to carry out the treatment, you know it's open. Now, closed treatment and some examples of closed treatment for fractures are traction, reduction, and manipulation, and also immobilization treatments too. This is kind of this could be this device, even though it's an immobilized device or a cast immobiles as well. It is closed and it is treating a fracture. Sometimes they use these devices to offer manipulation as well, or to put it back into place very slowly. And finally, percutaneous treatment. Some people kind of confuse open with percutaneous, but let's just say this. This is not an incision, more like a puncture through the skin. So they puncture the skin to treat, to access the bone, and they use pins, and the pins sometimes stick out, but no incisions were made. But I don't want to say sometimes in order for them to puncture, they might have to incise, but the difference so that they can open up the skin. But this is different from open, and here's why. The objective of incising is to insert the percutaneous tool, and the objective of the percutaneous tool is to treat the fracture. Whereas open treatment, the objective of the incision is to access the surgical site to directly treat the the fracture. So if it's if a small incision was made to insert a device, that is not considered an incision. Just saying. All right, so you might not even see that. Your documentation just might say percutaneous, and that's good enough. But if the incision was made for the procedure, that's open. If the incision was just to put in the port, then that's not open. It's percutaneous. Are you all with me? Good deal. All right, so I want to end things with this. Just know the type of treatment is not synonymous with the type of fracture, right? No. Let's say down here we have two fractures, and let's say these are two displaced fractures. But the one on the left came through the skin, and you can see blood. So this is an open fracture on the left, and on the right, it's closed because it did not penetrate the skin and you cannot see the tissue. However, they require the same procedure to repair, right? Yeah. So the doctor would have to incise this patient to get to the surgical site, as well as incise this patient to get to the surgical site. And these both are going to have open fracture treatment. So in sum, a closed fracture can have open treatment, like in this case. And an open fracture can have closed treatment, but it's rare. Okay. Oh, no, no, no. Yeah. Yeah, because, yeah, I think my son's was closed treatment. Yeah, that would probably be considered closed because the doctor did not open that surgical site. He just sutured it. Hmm. All right. An open and closed fracture can have percutaneous treatment. So, again, pay attention to the documentation. Let the documentation guide you. Don't get caught up in saying, oh, just like I just did, oh, my son's surgery was closed because the doctor didn't open it up. That's true. But if we just pay attention to the documentation, the doctor will tell you what they did. And we, as coders, our job is to code to the documentation. We code what we see and not what we think. All right. Also, just want to point out, we have spine surgery. We also have vertebroplasty. I talked to you about that, and kyphoplasty. You have arthrodesis. Um, two of these we will review, but just want you to know that they are here in the guidelines. This is where you can reference them, and it'll be very helpful. Now, I want to talk to you about scopes. Scopes, yes, scopes are pretty much consistent throughout CPT. However, some scopes have some nuances, and we're going to address one of them. But here are the basics when coding scopes. Know the difference between a diagnostic scope and a surgical scope. If the diagnostic scope becomes a surgical scope, the diagnostic scope is not coded, it gets bundled into the surgical scope. What does that mean, Mrs. J? Well, anytime a patient goes in for a diagnostic procedure, scopic procedure, the purpose of that is to diagnose a condition. However, anytime that doctor carries out a procedure within that scope, then it's not diagnostic. It becomes a surgical scope. That's what that means. Now, there are some guidelines that override this, and we're going to review those as well. So just know the difference between a scope used for diagnosing a condition and a scope used for carrying out a surgical procedure. Also, if an open procedure is performed with a diagnostic scope, the diagnostic scope is coded. And in some cases, they may require modifier 59. And watch those separate procedures. Yes, watch them. All right, so here is a visual. I want to give you a visual of a diagnostic versus surgical scope. On the left, you see an arthroscope, and you see the scope entered into the knee. Also, you see another scope. Well, it's not a scope, but it's an instrument. You see two more instruments. So there are three, and that's common into the knee joint. Now, if the doctor doesn't do anything, just diagnoses a condition, then it's a diagnostic scope. And anytime the doctor carries out a procedure within that same scope, like in our case, the doctor inserted a shaving tool to shave some bone, then it's no longer diagnostic. That's surgical, right? Yeah, so that's it. So I have an example. Now, you can definitely code along if you'd like, but this is an example, and I'm just going to walk you through it. Which codes best describe the encounter? A, 29882, B, 29870, C, 27403, 2987059 modifier, and 27403. Patient arrives to the ambulatory surgery center for knee arthroscopy or arthroscopy. The patient has been having pain for about 6 months. She is a college basketball player, and the physician suspects that she has a torn meniscus. The arthroscopy confirmed a medial meniscus tear. The physician removed the scope. Then patient was prepped and draped. Open exploration and meniscus repair was carried out. All right, what do we do? Well, here are my instructions in the top right, and this is something for you to follow, and eventually they'll go away, okay? So you read the last sentence, then you read the answers, then I'm going to highlight my diagnoses, my signs and symptoms and procedures, then I'm going to apply all guidelines. Well, in my case, we had a knee arthroscopy. I'm going to put my procedures in green as we're learning, then eventually we'll change the color scheme, but it should help you see at a glance what is a procedure and what is a diagnosis. So the patient had a knee arthroscopy. The patient had pain. The doctor suspects a torn meniscus. Then the doctor confirmed a medial meniscus tear. Then the doctor removed that scope and carried out an open exploration and meniscus repair. All right, so here are my inventory. Knee arthroscopy, that's a procedure. Meniscus, medial meniscus tear, that's a diagnosis. I did not document pain or suspected torn meniscus because they are integral to a medial meniscus tear. Then finally, I'm going to have to code for the open exploration and meniscus repair. All right, coders, you all with me? So if you're with me, I want to know what your thoughts are based upon some guidelines that we've just reviewed, based upon what you have remembered. What is your thought? One person said, hey, I think C is the answer, or I think B is the answer, or D. Outstanding. So, it's good that you can choose the answer. But just to give you a little heads up, most of these answers will be guideline driven or they may not be. I mean, most of them will be guideline driven, and the guideline might direct you or tell you to do something or not to do something. So that's a little clue. All right. So my advice is to do this. Go find the guideline in the musculoskeletal section in your MCG. And one of the guidelines I think that's applicable is the diagnostic scopes guideline. And this particular section within the guideline documented here says diagnostic scopes are coded separately if open procedure takes place. And watch separate procedures. I'm going to let that marinate. So now we know this took place because the physician removed the diagnostic scope and prepped and draped for an open meniscus repair. And because the physician did that, both are coded. So with that in our head,
We can consider this scenario. On the right, you see my image of my codes, and at the bottom, you see my inventory. So, for the purpose of this demonstration, I'm going to go ahead and chun my manual. All right, so the first code, 29870. I like this code because this is an arthroscopy of the knee, diagnostic, with or without synovial biopsy. And notice my separate procedure is highlighted and it's within the parentheses. All right, so I like this procedure did take place. This patient did have a diagnostic knee arthroscopy. How do you know it's diagnostic? Because the patient came in for a knee arthroscopy because the doctor suspected that they had a torn meniscus. Then a surgical that diagnostic scope was removed and the doctor carried out an open procedure. So a diagnostic scope did happen. I like it temporarily. Also, I'm going to go ahead and circle my family. This is a big family, right? Yeah, so let's go ahead and notate so we can see what each code is at a glance. All right, 29871. This is the code for arthroscopy knee surgical for infection, lavage, and drainage. So I just need to know. I'm putting out those key words so I can see it at a glance. 29873, this is for lateral release. 29874, this is for foreign body removal. 29875 is synovectomy limited. 76 is synovectomy major. 77 is for debridement or shaving. 29879 is abrasion, arthroplasty. 29880, this is for a meniscectomy, medial and lateral. 29881, this is meniscectomy, medial or lateral. Okay, coders, make sure you pay attention to these ands and ors. Remember, in CPT, and means and, not and or, right? That's only in ICD 10 CM. So pay attention to those game changers, and they even have them, in um, they have them highlighted so that you can see it. So that's a game changer. 29882. This is meniscus medial or lateral repair. And 29883. This is meniscus medial and lateral repair. Yes, these are game changers. So make sure you box them so you don't miss them. Now, if we look at 29882, 29882 is coming up wrong. Why is it wrong? Because if you read the whole code language, let's go to the parent and read arthroscopy, knee, surgical with meniscus repair, medial. That looks right, but what's wrong is this procedure was carried out in the scope. It is a surgical scope, right? So maybe you should write that these are surgical scopes if you need to. As you can see, we've documented that the diagnostic scope is diagnostic. That means they didn't carry out any surgery. So it might be good to say that this family is a surgical scope family. So that's why 29882 is wrong. Let's get rid of it. Now, what's the next code? This 29870, I like it because it's a diagnostic scope, but I don't like it by itself because it's not coding for the meniscus repair. So we're going to get rid of B. And that leaves us with both C and D. And what is the difference between the two? Well, C is coding for the diagnostic scope and D is not. Now I need to go back to something. I need to go back to the guideline, but before I do that, I want to show you that 27403 is an arthrotomy with meniscus repair of the knee. So it's essentially saying this is an open procedure, right? An open meniscus repair. I like this code. I also like 29870 because we did carry out both procedures. But the answer is going to be D. Here's why. The guideline, right, coders? The guideline. It says when a diagnostic scope occurs simultaneously and in the same setting as a surgical scope, it's bundled. This is not our case. A diagnostic scopes are coded separately if an open procedure takes place. This is our case. However, look at number 3. Separate procedures are coded separately if an open procedure takes place. However, separate procedures are not coded separately if not integral to a more complex procedure. Coders, is our separate procedure related? Here's a separate procedure. Is our diagnostic scope related to this meniscus repair? Absolutely, it is. It is. And we see this separate procedure, we see this guideline. And coders, earlier I said the guidelines at the code level are not parenthetical guidelines. You know what, coders? I'm going to walk back on that. Yes, they are. This separate procedure is a parenthetical guideline. It is in the parentheses, and that makes D correct. Now, some of you might say, well, um they might have the 2024 MCG manual. If you've got the 2024 MCG manual, then yours is not written out like this. However, the 2025, we've taken the steps to kind of write out how to consider a separate procedure, but it is the same. You should already know how to consider a separate procedure. In other words, if that separate procedure is related to a more complex procedure, it's bundled if occurs in the same setting. So you all probably already know it. This just kind of walks you through it a little more. So that's one of the differences between 2024 and 2025. All right, coders. So if you said D, outstanding. And this was this is a complex one. So if you got that correct, you know what? I applaud you. I applaud you. So before I go, just want to draw your attention. Don't forget to box those game changers, okay? The capital letters, that's unprecedented. You don't see that often. But if it's capitalized like that, definitely box it. Box it anytime you see and, or, each, etc. All right, I'm done. Let's continue.
All right, which codes best describes the encounter? A, 29830, B, 29830, 29834, C, 29834, D, 29835. Mary presents to the OR for a diagnostic arthroscopy. She is a recreational tennis player and has had tennis and had elbow pain for the past 2 years. The physician inserted the arthroscope into the synovial joint and determines that the patient has foreign bodies present from a prior injury and is likely the source of the patient's pain. The physician removed the foreign bodies, then removed the scope. The patient was discharged home in satisfactory condition. All right, coders. So do you probably don't. I didn't really hone in on this guideline. Now, I think it's time for us to do it. But if somebody knows the guideline, go ahead and put it in the chat. Go ahead. I am going to celebrate you. All right. All right. So I'm going to pull the guideline out. And somebody says, hey, so when we code another procedure, should you use modifier 59 if it's from a different body area, if it's from the same, or if it's a different procedure, like open and closed are different, then you can use modifier 59. Great question. All right, so first thing I'm going to do with this, I'm going to highlight my keywords: diagnostic arthroscopy, elbow pain, inserted an arthroscope in the synovial joint, foreign body from prior injury. The doctor removed the foreign bodies. All right, coders. We're going to talk about what you should highlight and what you shouldn't very soon. But essentially, The green represents the codable procedures, and the yellow represents the codable diagnoses, and the pink are integral, or if you just don't know what to do. But specifically, when it comes to highlighting for procedures and CPT coding, you're going to code or highlight what the procedure is. And anything else done to carry out that procedure is pink. So often it's bundled or included and not coded separately unless there's a guideline or documentation that says you code it out, you break it out. All right. So don't feel like you have to, you know what should be coded separately and what shouldn't. Your guidelines will drive you. So you have to be forensic, and that's it. Hey, we got this, right? All right, so here's my inventory. We have diagnostic, arthroscopy, elbow pain, foreign bodies in the synovial joint, and removal of those foreign bodies. Right away, I'm going to get rid of the elbow pain because it's integral to the foreign bodies in the synovial joint, right? Yeah. Now, which guideline is applicable? Well, the diagnostic scopes again. Remember, when a diagnostic scope occurs at the same time in the same session as a surgery scope, it is not coded. It's bundled into the surgery code. That's our guideline. But did this diagnostic scope become a surgery scope? Well, there's another guideline. That's why it's important to read everything. Diagnostic scopes bundle the following procedures: removal of loose or foreign bodies removed from the same or same sized cannula used for the procedure. What does that mean? Well, that means diagnostic scopes include foreign body removal from the same cannula, the same tube attached to the scope. So in other words, if our documentation says that the doctor replaced the tube to create replaced it with a larger tube or cannula, then you can code those foreign bodies. If the doctor did not, then you cannot code the removal of the foreign body. I'm gonna let that marinate. Now, where does this come from? It comes from the guidelines. So if you go to the endoscopy, arthroscopy section in the musculoskeletal section, you'll see the guidance right underneath. Arthroscopic removal of loose bodies or foreign bodies, 29834, may be reported only when the loose bodies or the foreign bodies is equal or larger than the diameter of the arthroscopic cannula used for a specific procedure and can only be removed through a cannula larger than that used for the specific procedure, or through a separate incision, or through a portal that has been enlarged to allow removal of the loose or foreign bodies. So our documentation has to say that the doctor had to use a larger cannula, or had to create a separate incision, or had to create a portal, or had to enlarge the portal for the removal of these foreign bodies. And our documentation just does not say that, right? So this 29834, we're not going to code it because this is not our case. What happened was the physician inserted the arthroscope, removed the foreign bodies, then removed the scope. There's no mention of switching out the cannula, no mention of enlarging the portal, no mention of a separate incision. So that means that the foreign bodies are bundled, the foreign body removals are bundled into the diagnostic scope. So we're going to get rid of 29834. Gotta go. We're going to get rid of B2 because it's coding for both 29830 and 29834. They're coding for the diagnostic scope and the surgical scope, and that is not correct. And also, coders, they are sequenced wrong. Anytime you can code a diagnostic and a surgical scope, the surgery is going to be sequenced first. So that's another reason you knew that was wrong. Gotta go. Now, the last code, oh, it's not last, 29830. This is the code for the diagnostic arthroscopy or arthroscope, and it is correct. And remember, the separate procedures can't be coded with related procedures unless there's some kind of guideline. And in our case, um, it just wouldn't be applicable. But just know you can't code them together, and they better be sequenced right. And this 29835 is incorrect because this is for an arthroscopic synovectomy partial. There's no mention of this synovial joint being removed or partially removed. No, there are foreign bodies in the synovial joint, but that would be incorrect. And the correct answer is A, 29830. And I kind of feel like I didn't do this justice because I don't know where I stopped talking. So I want to know how you feel about this. In sum, foreign bodies are bundled in the diagnostic scope unless the physician had to change the cannula to allow for a larger cannula. If the physician had to incise a different site, open up a different site to remove the foreign bodies, or the physician had to enlarge the current site. There's no mention. All right. All right, so I got a little bit of a response. So the answer is A.
Now, I just want to leave you with this. Trust your guidelines, and there is a hierarchy. Number one, your parenthetical guidelines outrank. Number two, you have code series or chapter guidelines, typically under the blue bold, and they can be under the red bold, as we've seen. And number three, your general coding guidelines. And again, a parenthetical guideline is any instruction or guideline within a parenthesis. All right. So I'm going to walk back on that separate procedure. That's definitely a parenthetical guideline. All right. So you'll see some things at the code level in parentheses. They aren't instructions or guidance. They might be clarification terms, etc. But anytime you see an instruction or guidance or rule in a parenthesis, it's a parenthetical guideline. All right. So now, oh, and also, if there's no guideline, trust your keywords. The keywords in your inventory should match the keywords at the code level, right? So you're always going to match them, but if there's no guidelines, go ahead and trust those keywords. Now it's time to test your knowledge. It's time for you to do your thing. But first, how to solve a CPT scenario the AMCI way. There are 3 steps. Step number 1, you will inventory. So that's pretty much write down all procedures and diagnoses and those signs and symptoms in your documentation. Just write them down. Number 2, review any pertinent guidelines and apply them in order. We've learned that parenthetical guidelines are first, those blue heading guidelines are second, and those green page guidelines, those are your general coding guidelines, those are third. So if they all apply, apply them all. But if they override one another, you know what to do. Your parenthetical will be your highest ranking. Then after you apply the guidelines, select the code that best matches your keywords if there is no guidelines. So essentially, keyword concept is matching your list to the code's language. So the keywords that you've pulled out in your list should match the keywords of the code, unless there is some guideline superseding it. So that's pretty much it. So if there's no guideline, strictly use the keywords. If there are guidelines, follow those and select your codes. Steps 1, 2, and 3.
So here's my scenario. This is not one for you to do. This is just kind of exercise, and then we're going to move on to yours. Of the following, which best describes the encounter? 20600, 20604, 610, 611. Patient with a history of hip bursitis arrives at the orthopedist's office for a therapeutic injection of hydrocortisone with ultrasound guidance. All right, so that's my scenario. There's my chun. I'm going to highlight my key terms: hip bursitis, injection of hydrocortisone, and ultrasound guidance. So what are you going to do, Mrs. J? Well, my book is chunned, and I'm looking, all right, this is for the small joints, this is for the medium joints, and this is for the large joints. But I don't know if it's a small or medium, so I'm looking in the parenthesis. A medium joint is your temporomandibular joint, your acromoclavicular joint, the wrist, elbow, or ankle, olecranon, bursa. These are all medium joints. So let me go down and look. Shoulder, hip. Yes, this is where I'm going to code from, right? I'm going to code right from there. So my code has to be in here. And the first code is with ultrasound, second is without, and this is without, oh no, this is with ultrasound. So my answer, this is without and this is with, and this is with. And so my answer is D. All right, coders. You see how Chun works? It does help. And you are awesome. You are saying D, 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 D. Outstanding. Good job. Now it's your turn. But remember, if you want to learn Chun, go to the Chun party on Facebook. Some of your peers have shared their Chun, and you can find them in the albums. So go to the musculoskeletal album to look at musculoskeletal system Chun. All right, coders, I'm done talking. I want to know what you know. I want you to practice. You ready? All right. So, without further ado, I'm going to ask Dr. C to come to the floor to read these scenarios for us. Dr. C, please and thank you.
All right, coders. Thank you, Mrs. J. Thank you for that amazing and wonderful instruction. I know we all learned a lot and had a lot of aha moments, and now we're going to show it. The question is, what procedure code is reported? Is it A, 27503 with modifier RT, B, 27508 with modifier RT, C, 27506 with modifier RT, D, 27510 modifier RT. Joe was in a motorcycle accident and fractured his right femur. The surgeon placed an intramedullary locking implant nail through a buttock incision. What procedure code is reported? Good luck, coders. You have 2.5 minutes to solve.
All right, I know I'm a little early, but a lot of you've answered. And somebody said they chummed this section and it helped a lot. And let me tell you, that person who answered almost, I don't know if she answered first or not, but she's often first. So I thought I would share that with you that Chun is showing that it works and it makes you faster. And while we're learning, it's not important that you be fast, but it is important that you learn the importance of that because ultimately the exams are timed. So take your time while you're learning, but as you get stronger, definitely move towards increasing your speed. All right, excellent job, everybody. Now, what do we do first? Well, we highlight our key terms: fractured, right femur, intramedullary locking implant through a buttock incision. And these are my key words: fractured right femur, intramedullary locking implant, and buttock incision. And I just want to show you what this looks like. Yeah, here's an intramedullary locking implant, and the incision went through the buttock. You can't see it, but it's it's going this way, down through the buttock. Now, which guideline? Is there an applicable guideline? Coders, did you all use a guideline? Type in the chat. Anybody use a guideline, or you just coded it right out? Everybody got the same answer, so you all rocked it. You did. All right. So somebody said no, no. Somebody said yeah. All right. Well, this is the guideline that I use because I'm learning, right? So I said that I had to pay attention to my keywords and I had to pay attention to the treatment. Is it open treatment? Yeah. I had to do that. Oh, let's go back. And yes, it is open treatment because there was an incision. The doctor surgically incised to treat the fracture, right? All right. Okay, so here are my codes on the right. Down below, my inventory to keep me focused. And we know this is open treatment, right? The type of treatment is open because the doctor made an incision through the buttock. So off bat, 27503, this is closed treatment. And because it's closed, I'm not even going to read anything else. I'm going to say it's incorrect. In A, you have to go. You are a distraction. So 2 is B, 27508. This is the code for closed treatment. No need to go any further. And B is incorrect. Also, D is incorrect. 27510, closed treatment. Gotta go. And it's not important to read it because it's wrong. It is the wrong procedure. And the correct procedure is 27506, open treatment of femoral shaft fracture with or without external fixation with insertion of intramedullary implant with or without circlage and or locking screws. This is our code. And all of you said C, outstanding. All right, it's time for the next one. Go ahead, please, and thank you, Dr. C.
Okay, coders, great job on that one. And the directions say code the procedures. A, 20553, B, 20610 times 6, C, 20552 times 4, D, 20552 times 6. Patient complains of chronic acute arm and shoulder pain following bilateral carpal tunnel surgery. Patient is followed by pain management for over a year. Physician finally diagnoses patient with reflex dystrophy syndrome, RSD. Physician performs 6 trigger point injections into 4 muscle groups. Code the procedures. Good luck, coders. You have 2.5 minutes.
All right, coders. Good job. A lot of you did amazing. And maybe some of you maybe have overthought this. I don't know, but let's take a look. All right, our keywords. Reflex dystrophy syndrome. 6 trigger point injections into 4 muscle groups. All right, this is my inventory. The RDS, 6 trigger point injections, and 4 muscle groups. Does anybody know what RS, is it RSD? RDS, I think that's backwards. RDS is. Anybody know? It's in the news now. Anybody see Take Care of Maya? It's on Netflix. Okay, don't watch it. Watch. She's on trial now, and all right. I wouldn't watch it if you because I think it's heavily. It doesn't include the facts. It's a very passionate movie. Don't. I mean, you can watch it definitely, but it's in the news now. If you want to know the facts, don't watch that because you'll definitely be. Your heart will be tugged. It will, it will kind of draw you in and your heart will play a role in it. But I'm glad I didn't watch it because I'm seeing things a little differently. And here's why, because of medical coding. This little girl, Take Care of Maya, she has a condition called RDS. In other words, it's called complex regional pain syndrome. Her mother and father, particularly her mother, has taken her to Mexico to get this treatment for this condition. She had to go to Mexico. And the treatment worked for a little while. Then she came back to the US. She went to Johns Hopkins University, and Johns Hopkins said, that treatment is not appropriate for that condition, and there's something wrong with you. So the mother got very frustrated, long story short, and she commits suicide. So the family is now suing Johns Hopkins for $200 million, and the hospital was alleging that the mother had Munchausen's by proxy. If you watch the movie, most people that do aren't hearing the facts. They're saying hospital is wrong. I'm keeping my ears and eyes open for the facts. So I don't know. So if you want to know, if you want to look at it unbiasedly, wait until after the proceed after the hearing, and then watch the movie. All right, I digress. So Maya allegedly has this complex regional pain syndrome or RDS. And here are the clinical indicators: the skin texture and color. The skin has a different texture and color and temperature. Also, there's swelling in the limbs, decreased function, reduce in or increase in hair and nail growth. So they have these distinct features, and it looks like this. In the first image, you can see how red the hand is, and it's usually warm to touch. And down below, you can see the swelling as well. And I think A is a very extreme case. And then also there's another image of A, and also a X-ray image where you can see all of the swelling. So this is what the Maya has or had. I'm not sure. So definitely pay attention to it, pay attention to the facts, and you can't go wrong. All right, I digress. I'm back. These are the key words. Of course, we have RDS, 6 trigger point injections, 4 muscle groups. And I chose the introduction/injection guideline. Code series 20500 through 20615, and your keywords. Trigger point, this is your point of pain. Bursa, that's your sac near the joint, and muscles. So we have a lot of these keywords, so that's why I chose this code series. And it tells you it's coded based upon the number of, you need to know the number of muscles and joints, and we do 4 muscle groups, 6 trigger point injections. And it says watch the type of joint, and finally, not coded according to the number of injections. All right. Now I'm going to take that information and I'm going to go ahead and code it out. And it says 26016 is incorrect. Although this is an arthroscentesis, this might not be correct, but look, and or injection. So that's wrong, right? The injection is correct, but this is not a major joint. We already learned that shoulder, hip, knee, subacromial, bursa are considered major joints or bursa. And this patient actually had carpal tunnel that's in the wrist. So that would be like medium, right? So this is wrong. Gotta go. And also, you look at number 4 down here. It reminds us to code according to the number of muscles, not injections. And if we go to 20552, the parent is injections and then 1 or 2 muscles. No, we have 4 muscles, 4 muscle groups, 4 muscles, and this is not enough. So 20552 is incorrect. And let's go down. So B and C are wrong, and A is correct. Injection, single or multiple trigger points, 3 or more muscles. And this is our answer. So if you said A, outstanding. If you learned something, that's priceless. All right, how are you feeling, coders? Good deal, good deal. All right, we got another scenario. Exercise number 3. Dr. C, please, and thank you.
Okay, coders, take a deep breath. We are in it now. Of the following, which best describes the encounter? A, 22810 and 20930 and 22840. B, 22818 and 22840 and 20930. C, 22802, 22842, and 20930. D, 22800, 22842, and 20930. Dr. Wilson performed a spinal arthrodesis on Mrs. Brown with a posterior approach, focusing on segments L3 through L5. The patient was placed in a prone position and a midline incision was made over the lumbar spine. The paraspinal muscles were dissected to expose the L3 through L5 vertebral segments. Following proper preparation, Dr. Wilson proceeded to fuse the vertebrae using morselized donor bone graft with posterior segmentation instrumentation. The alignment was verified using fluoroscopy. After ensuring the stability of the fusion and checking for any potential complications, the incision was closed in layers. Of the following, which best describes the encounter? Good luck, coders. You have 2.5 minutes to solve.
Okay, I am loving it. You all are rocking. Outstanding. Outstanding. You don't need me. You don't need me at all. Impressive. All right, so here are my keywords. A spinal arthrodesis, posterior approach, segments L3, L5, lumbar spine, L3, L5 vertebral segments, fuse the vertebrae using morselized donor bone graft with posterior segmentation, instrumentation using fluoroscopy, and the incision was closed in layers. So I just want you to know this is kind of long. There are a few procedures going on here. And I want to just reiterate that you highlight anything, how can I put it? You just highlight the procedure and anything done to carry out that procedure is typically not coded additionally. So I'll kind of put it in yellow, right? Not yellow, pink. Now, if there's a parenthetical guideline that says, hey, you need to code it additionally, or there's some guideline, then I'll code it. But for the most part, anything done to carry out the procedure is not coded additionally, typically. So here is my inventory. Spinal arthrodesis, that's your procedure. Posterior approach, you need to know how the doctor approached your spinal procedure. L3 through L5 segments, your lumbar spine, and fused L3 to L5. I'm going to get rid of that because fused is the same as arthrodesis. That's fusion. Arthrodesis means fusion. That is your procedure. So I'm going to get rid of it because it could be distracting to me. Also, I'm going to get rid of lumbar spine because I know what L means. L means lumbar. I know they're operating in the lumbar region. All right, so everything else can stay for now. I kind of want to get rid of fluoroscopy, but I'll leave it for now. All right, so just want to let you know that this is a spinal arthrodesis of the L3 through L5 posterior. Okay, so we are having our procedure here. This is not really L3, L5 over here. That's the best I can get, but it's right here. L3, 1, 2, 3. L3, L4, L5. And arthrodesis procedures are often carried out with bone graft. You need the bone graft to help stabilize the area. You know, often it's unstable, so you need bone to help stable it. And then the instrumentation also reinforces it. So that's what we did. Now, which guideline am I going to grab? I'm going to grab the arthrodesis guideline. And it says it includes bone grafts and instrumentation. Code series 22532 through 22819. And essentially, I just kind of read, and it says you need to know what the approach is. If I look over here, we're good. And also, too, this is spinal arthrodesis. I'm in the right guideline. I see my approach is posterior. Also, it says the number of levels depends on the number of spaces. Okay, so we know that. Also, it says, oh, I'm sorry, I skipped over instrumentation. Yes, we did use instrumentation, and it says the number of levels depends on the number of spaces. We know L3 through L5 segments, so if we know that, we can also deduce that there are 2 spaces. And they also mention that, and we also know that there are 3 segments too. And they also mention that we have to use modifier 62 for co-surgeons, no mention of co-surgeons. Also, decompression on the same segment or space as posterior lumbar interbody fusion that includes laminectomy, festetectomy, or foraminotomy is separately reported. This isn't our situation. They said use 27279 for percutaneous stabilization of the SI joint. We're not there, we're in the lumbar spine. And 0775T for the intra-articular stabilization that does not transfix the SI joint. We are not in the SI joint, not applicable. So we've got some information. Now let's go ahead and solve. All right. So 22808 family says anterior arthrodesis, and therefore 22810, which is the indented code or the child of that family, and it's also at A, it's wrong because it's the wrong approach. This is anterior approach. Our circumstance is a posterior approach. So if the language before the semicolon at the parent level is wrong, that's the common language portion. If the common language portion is wrong at the parent, then the entire family is also wrong. So we're going to get rid of A. 22810 is wrong. Also, B has 22818. And if you look here, this is the code for kyphectomy. Kyphectomy is pretty much dealing with the thoracic region. If you think about kyphosis, that's Hunchback. Hunchback of Notre Dame had kyphosis. His thoracic, he had abnormality in the thoracic region. So 22818 is incorrect because a kyphectomy did not take place. Circumferential exposure of the spine and resection of vertebral segments, including body and posterior elements, single or two segments, didn't happen. And also, our procedure is in the lumbar region. Gotta go. All right. C, 22802. Okay, let's go ahead and read the parent. Arthrodesis, posterior. Indeed, ours is the posterior approach, or spinal deformity with or without cast, up to 6 vertebral segments. I like it. I do. Don't we have 3 segments? Yeah. Okay, so look at 22802. This is 7 to 12 vertebral segments, not our surgery. So this is too many segments. Let's go ahead and let's get rid of 22802. You gotta go. And our correct first code is 22800, arthrodesis of the posterior approach. Now, I wouldn't be right if I didn't do my due diligence and finish this out, because I want you to see what else is coded, commonly coded with arthrodesis. And I want you to remember your keywords and forensic reading really drove this answer, not really guidelines, right? All right. So we also know when we're coding for arthrodesis, instrumentation is also coded, right? And in our situation, we had segmentation in instrumentation. And I pulled this image right from your CPT manual, and this is what it looks like. It's in multiple pieces. Also, bone grafting is included. What they do is take the bone from the donor and morselize it, like that. Then they take that morselized bone and blood, often from the patient, and they mix it up. And it does look like ground meat. It does. So this is what bone graft looks like. Then when it's of the right consistency, they place it in the location that they, in the desired location, in our case, in L3 through L5. So this is what the coding looks like. The next code, 22842, instrumentation is going to be sequenced before the bone graft. And if you look, 22842, posterior segmental instrumentation, 3 to 5 vertebral discs. There you go. Or excuse me, vertebral segments. Please forgive me. There you go. It is an add-on code. And your allograft, which is your bone graft, morselized, or placement of osteopromotive material for spine surgery only. And there you go. It's going to be sequenced in this order. And if you said D, outstanding. How do you feel, coders? How do you feel about musculoskeletal system? Someone said better. Good, great. All right, it's time to move on. Let's do it. We're going to speak briefly about the respiratory system code series 30,000 through 32,999. And it's important that you know some parts of the anatomy, right? The anatomy of the respiratory system. And if you want to follow, if you want to type in the chat, go ahead. So if I point to number 1, go ahead, type what we call this. What do we call number 1? If you said that this is the patient's mouth, right? That's the oral cavity. Way to go. Number 2, what is number 2? Well, number 2 is the nasal cavity. Number 3, here's number 3. Number 3 is the trachea. Number 4 is the bronchi. Number 5 is the bronchiole. Number 6, alveoli. Number 7, what is number 7? Number 7 is the right lung. Number 8 down here is your diaphragm. So these are the general parts of the respiratory system. Now, if we want to go just a little bit further so that we can code some specific procedures, it's important that you know the anatomy of the lungs. Well, in your homework, you learned that the right lung have 3 lobes and the left lung have 2 lobes. And those lobes are referred to as, on the right, the upper is the superior, the middle is the middle, and the lower is referred to as the inferior lobe. And on the left, you have your upper lobe, which is your superior lobe, and the lower, inferior. Yeah. So just remember the right lung have 3, left 2. And don't confuse a lobe with the lung, right? I'm going to show you, okay? Now that we've moved on into the respiratory system, it's important that you know the guidelines. And yes, the general surgical guidelines apply. So always reference them if you need to. And also, in the MCG manual, just like in musculoskeletal, we have specific guidelines, and you can see on the right, we have lung transplant scopes, lung lobe definitions, etc. And just like scopes in surgery, when you're coding scopic procedures in the respiratory system, diagnostic scopes are bundled into the surgical scope. Are you ready for a respiratory coding exercise? Okay, I know we moved a little faster, but you guys are a little advanced. Okay, let me tell you a few things. All right. Well, the respiratory procedures, just like musculoskeletal, they progress downward from the head to the thorax. The anatomically, that's the way it goes, down. All right. Don't forget to read your parenthetical guidelines. These guidelines provide instruction on how to use specific codes. And don't forget, they're guidelines. Yes. Most codes in the respiratory section are unilateral, so watch for bilateral procedures. Go ahead, make sure you use modifier 50 if a bilateral procedure is performed, unless the descriptor indicates that this is coding for a bilateral procedure. So if the descriptor indicates bilateral, you don't use a modifier, and that's in general throughout CPT. If the descriptive includes it, don't append it additionally. Again, diagnostic scopes are bundled. And know your surgical suffixes, those ectomy, otomy, ostomies, scopies. They're very, very helpful in the respiratory section. All right, coders, it's time to bring Dr. C to the fore. Please and thank you.
Thank you, Mrs. J. Thank you for your wonderful explanations. The question is, which CPT codes best describe the VATS therapeutic wedge resection of the left upper lobe followed by left upper lobectomy? The answers are A, 32480, B, 32505 and 32480, C, 32663 and 32666, or D, 32663. Which CPT codes describes VATS therapeutic wedge resection of the left upper lobe followed by left upper lobectomy? Good luck, coders. You have 2.5 minutes to solve.
Great. Great job, coders. Great job. You all tackled this one. And I think some of you are going to have an aha moment. And, don't shy away from those. Don't feel like you got to get everything right. If you do, then that means you already knew this stuff, right? And if you did, that's even better. But it's always good that you're able to learn something, especially if it's a nuance, right? Yeah, so don't be tough on yourself. All right, my keywords: VATS, therapeutic wedge resection. And this was carried out on the upper left upper lobe, followed by a left upper lobectomy. All right, coders. So let me tell you, this VATS is the acronym for video assisted thoracoscopic surgery. And a wedge resection was carried out. Now, VATS is a minimally invasive surgery of the chest for procedures in the chest and lung. And this is carried out by inserting 3 instruments. The first one up here, you'll see, is a surgical instrument. The next one is also a surgical instrument. And then this one here is your laparoscope. That's where your camera is. And they get these instruments in by way of a trocar. These trocars they poke holes through the skin to enable those instruments and cameras access. And to carry out this VATS, video assisted thoracoscopic surgery, wedge resection. Oh, by the way, wedge resection is a biopsy. We sometimes refer to it as a wedge resection or excision. It's a biopsy, but it's more complex than a typical biopsy. A typical biopsy will just take a snip of tissue and it's sent off to pathology. A wedge biopsy takes more tissue. And you know what? I have an image over here. And right here, this first image, this is a wedge resection, and it is a biopsy, and it's called wedge because it's often in the shape of a wedge like this. So it's a wedge resection. It is indeed a biopsy. And remember, biopsies are taken or they're carried out for diagnostic purposes, right? Okay. All right. Next, another lung procedure, and it's more complex than a biopsy or wedge resection, a segmentectomy, or you can call it a segmental resection. In other words, they're taking a piece of a lobe. Remember, the right lung has 3 lobes. They're just taking a piece of one of those lobes, and the remainder of the lobe is intact, left intact. All right. And then another procedure on the lung is a lobectomy. That is total and complete removal of the entire lobe. So if you have 3 lobes on the right, after or post lobectomy on the right, you will have 2. And finally, you have a pneumonectomy. A pneumonectomy, that's removal of the entire lung. So it's important that you know these procedures and don't confuse a lobectomy, which is a removal of a lobe, and a pneumonectomy. Why are you saying that, Mrs. J? Because I used to do that. All right. Okay, so let's go back to our scenario. So our inventory, we have VATS wedge resection, left upper lung lobe, and left upper lobe of the lung, and left upper lobectomy. So what really happened was this patient had a wedge resection, a biopsy, followed by a lobectomy. So let's go and see if there's some guidelines. Here's a guideline for therapeutic wedge, and that's exactly what we had. However, there's another guideline called lung biopsy. And I kind of like this one. I like this one better because if you look, it addresses the VATS procedure. So if you, let me go ahead and get rid of that. And it says VATS, video assisted thoracic, the upper chest, right? Surgery. And it says diagnostic biopsies are bundled in major procedures. A major procedure is a segmentectomy, a lobectomy, thoracoscopic VATS lobectomy. Well, we did have a lobectomy and we did have a biopsy, right? So if they're bundled, then we're not going to code the wedge resection. That's a biopsy. And we're only going to code the lobectomy. So now we're going to go to our codes, knowing what our task is. So if you look at A, 32480, this is removal of lung. That's incorrect. We're not removing a lung, we're removing a lobectomy, a lobe of a lung. Look at B, 32505 and 32480. We know 32505 is wrong because thoracotomy with therapeutic wedge resection. This isn't even a scopic procedure. Let's really remember that this VATS is a video assisted thoracoscopic procedure. This is an open procedure, 32505. And also so too is this one, 32480. So B is doubly wrong. It's coding for thoracotomy, it's coding for the wedge resection, and it's coding for the removal of the lung. Gotta go. And it's even sequenced wrong, doubly wrong. All right, so let's look at C. C is coding 32. Okay, I think this was a mistake, but this 32650, no, it's correct. 32650, this is the parent thoracoscopy, surgical with lobectomy. Okay, we did have this thoracoscopic procedure, and the lobe was removed. 32663, I love it. So this is correct. And remember, the biopsy is bundled into the lobectomy. So when we look at 32666, this is with therapeutic wedge resection. So that's coding for the biopsy. And we're told we do not code them both. We're only going to code one, the lobectomy. So 32666 is incorrect. And the answer is D. How you feeling, coders? All right, so we have 5 minutes left and we have 3 more scenarios. I'm going to continue, so if you have to leave in 5 minutes, you may be excused, okay? All right, I love the fact that some of you are feeling good, and I love it. Someone said, great forensic teaching. No, you are forensic coding. Way to go. And thank you. I thank you too. I love it. I love it. I love it. All right, we have another scenario. All right, Dr. C, if you have to leave, you may, and let me know.
I am not leaving. I am not leaving all this excitement. All right.
Thank
What
you.
CPT code is reported? A, 38500, B, 38510, C, 38520, or D, 38542? A patient with adenocarcinoma of the larynx has developed cervical adenopathy and is undergoing an excisional biopsy of the right cervical node. An incision is made above the clavicle and dissection taken down into the muscle. Blunt dissection was used to work the way down to the node, which was firm and white. The entire node was taken and the wound was closed. What CPT code is reported? Okay, coders, good luck. You have 2.5 minutes to solve.
Outstanding, outstanding. Okay, coders, here are my keywords. Adenocarcinoma of the larynx, cervical adenopathy, excisional biopsy right cervical node, incision, muscle, entire node was taken, and these are my keywords. As you can see, the pink was not documented because I'm not going to code it, because remember, anything done to carry out the procedure is not coded typically, but it could be, so I have placed it in pink. Okay, now I just want to tell you that these cervical nodes, or yeah, cervical nodes, you got quite a few of them. And I went to kind of just study where these where our cervical nodes are, and the lymph nodes, of course, and they're right here along the crease, and especially specifically, all of these are cervical, but especially when talking about our um, deep cervical. Here you go. All right, I kind of gave it away. They are pretty deep. How do you know they're deep? I'm going to show you. Okay, so here are the codes. 38500, that's at A. It's coding for a biopsy or excision of lymph nodes. Open superficial. I don't like this superficial. And why don't you like it? I don't like it because they took that dissection down to the muscle. If they're going past the skin and down into the subcutaneous muscle fascia, that is not superficial. All right. So anytime they have to dissect past the skin, the true skin, epi, the dermis, it's not superficial. So they went down to the muscle. So I'm getting rid of A. Okay. Also, 38510. This is a biopsy or excision of lymph nodes, open, deep cervical nodes. I think they are deep because they went down to the muscle. But if you look at 3520, this is deep cervical nodes with excision of scalene fat. There's no mention of excision of scalene fat. So we're going to eliminate 38520 because if the doctor didn't say it, it didn't happen. But I do like this 38510. And then we also have 38542. This is coming up wrong because this is dissection of deep jugular nodes. We have cervical nodes. So this is definitely the wrong area or the wrong lymph node. And that leaves us with B. I like B. Biopsy or excision of lymph nodes, deep cervical nodes. We know it's deep because it did go down to the muscle. And if you said B, outstanding. All right, we got another one. All right, Dr. C, please and thank you.
Okay, coders, what CPT code or codes should be reported? A, 31622, B, 31622 and 31628, C, 31628 times 3, or D, 31628. A 50-year-old patient is having a diagnostic bronchoscopy performed. The physician inserts the scope and notices some suspicious tissue and decides to take 3 transbronchial lung biopsies from one lobe. What CPT codes should be reported? Good luck, coders. You have 2.5 minutes.
All right, we're going to speed things up because you did. Outstanding. Outstanding. Lots of fantastic answers in the chat. Good job. Good job. Good job. I just want to make sure I'm looking at the right thing. Yeah. Hmm. All right. So all right, good job, everybody. All right, so we have a diagnostic bronchoscopy and 3 transbronchial lung biopsies from one lobe, right? So those are our key words, the diagnostic bronchoscopy. And during that procedure, they found 3 transbronchial lung. They took 3 transbronchial lung biopsies. Sorry about that. Okay, so here are the guidelines that I'm going to use. the lung biopsies, the diagnostic scopes are bundled into the surgical scope, right? And also the scopes say the same thing. So if you, whichever diagnosis whichever guideline you referenced, you are good. So essentially the diagnostic scope is bundled into the surgical scope unless there is a guideline that supersedes it. So let's go ahead. Let's look at our codes. Let's start with A, 31622. This is the code for bronchoscopy, rigid or flexible, including fluoroscopic guidance when performed, diagnostic with cell washing when performed. All right, this is a diagnostic scope. And we said that it's bundled into the surgical scope unless there is a guideline that tells us otherwise. So we're going to eliminate A anyway, because it's only coding for the diagnostic scope. Now let's look at 31628. This is the code for with transbronchial lung biopsies. So we know B's wrong anyway. We know B's wrong, and we cannot code this diagnostic with this surgical because the 31622 is a separate procedure. And if they are related, it is not coded. So we're going to eliminate B. Don't forget the separate procedure guideline also rules. Gotta go. And also, diagnostic scope is bundled. That's two reasons that you should have eliminated B. So all we have left are C and D. And if you look at the parenthetical guideline, it says 31628 should be reported only once, regardless of how many lung biopsies are performed in a lobe. Only once. And you have this language. See the parenthesis around the S? Biopsies, right? Yeah. So we're going to eliminate C because it's coding for too many units and it's violating this parenthetical guideline. And D is our answer. So if you had an aha moment, outstanding. All right, Dr. C, please and thank you. This is a big one.
It's a big one. Ready, coders? Here we go. Of the following, which best describes the encounter? Is it A, 32480, B, 32505 and 32480, or C, 32663 and 32666, or D, 32663? A 55-year-old male with a suspicious lesion identified in the left upper lobe of the lung on a recent CT scan presents for VATS therapeutic wedge resection. Procedure details. In the OR, the patient was placed in the right lateral decubitus position. General anesthesia was administered and a double lumen endotracheal tube was placed. A small camera port was introduced in the 7th intercostal space at the mid-axillary line. Inspection showed a well-defined suspicious lesion in the left upper lobe. A VATS therapeutic wedge resection was performed to excise the lesion, and it was sent for frozen section analysis. Pathology confirmed a malignancy of the excised lesion, and the decision was made to proceed with a VATS left upper lobectomy. Additional ports were placed, and dissection was commenced. The pulmonary artery veins and bronchus to the left upper lobe were identified, ligated, and divided. The left upper lobe was then freed from all attachments and removed from the chest cavity. The remaining lobes were inspected and no further abnormalities were identified. The lung was reinflated under direct visualization, ensuring no leaks. All instruments were removed and incisions were closed in layers. Of the following, which best describes the encounter? Good luck, coders. You have 2.5 minutes to solve.
Okay, coders, I see a lot of people stumped on this one. Maybe the size of the scenario stumped you, but I gotta tell you, I may have tricked you. Yeah, size doesn't matter. If you are carrying out the keyword concept, right? So let me humor you. I'm going to walk you through this. Suspicious lesion, left upper lobe of the lung. That's therapeutic wedge resection. There was a well-defined suspicious lesion. Then there's that wedge resection, excision of the lesion, frozen section analysis, confirmed a malignancy. That's upper lobectomy. Pulmonary artery veins and bronchus were identified and ligated and divided. And then removed from the chest cavity, re-inflated under direct visualization, and was closed in layers. Does this scenario sound familiar? Well, if it does, it should, because it's the exact same scenario. I just added more words to it. I even gave it a diagnosis right here. So we had a suspicious lesion of the left upper lung. I'm getting rid of that because we have a confirmatory diagnosis of lung malignancy. So I'm leaving that. And this is the same procedure, the same VATS, video assisted thoracoscopic surgery with the upper lobe lobectomy. Same procedure. So the same guideline applies, right? Yeah. So when you have a biopsy, it gets bundled into the larger or the more complex or major procedure. In our case, we had a lobectomy. This is the same exact procedure, same answers. So we're going to start with the removal of lung. No lung removal took place, just lobe removal. So we're going to eliminate A. Also, 32505, this is an open thoracotomy. That means they went through the chest, made an incision through the chest. Nope, that is a thoracoscopic procedure. So we're going to eliminate B. We're also going to read the parent 23650. This is a thoracoscopic surgical code, and this is a scope. Single lobe with lobectomy, single lobe, 32663. We like it, but we do not like this code with this therapeutic wedge resection or biopsy because the biopsy is bundled into the more complex procedure, the lobectomy. So C has to go, should not be coded together, and our answer is D. All right, coders, so what we learn? What did we learn? We learned these big procedures are nothing, and you can handle them. Just get to the meat. Get to the meat. Yeah, highlight those keywords and you will thrive. And don't ever be afraid of it, ever. All right, this is our final exercise. Look at that. I got my keywords up there. It's okay. Dr. C, take it away. And thank you, thank you, thank you.
All right, coders, here we go. Select the code that best represents the procedure performed. Is it A, 31231 with a modifier 50, B, 31230 with a modifier RT and 31230 with a modifier LT, 31233, or D, 31231? Jane has been experiencing difficulty breathing through her nose for the past 6 months, particularly during nighttime. She occasionally wakes up gasping for air and has daytime fatigue. Physical examination suggested potential nasal obstruction. Procedure. After obtaining informed consent, Jane was prepped and draped in the usual sterile manner. Local anesthesia was administered. Using a nasal endoscope, Both nasal passages were examined. Bilateral endoscopic examination revealed enlarged inferior turbinates and a deviated septum, causing significant nasal obstruction. Select the best code that best represents the procedure performed. Good luck, coders!
All right. I don't think that timer is 2.5 minutes. Thank you, everybody. Let's go ahead and highlight these key words. We have difficulty breathing through her nose, a nasal endoscope, bilateral endoscopic examination, enlarged inferior turbinates, and a deviated nasal septum. All right, so we've got a few things, but we know our procedure is a bilateral endoscopic exam. I got a lot of pink because it is needed to carry out the procedure. And the pink difficulty breathing through her nose is related to enlarged turbinates and deviated septum. And so too is the nasal obstruction. All right, let's go ahead and solve. But we're going to start with a guideline. Which guideline are you going to reference? Well, endoscopy of sinuses. And it basically, the main guideline that I'm looking at is watch bilateral and unilateral language. Scopes that include inspection of the interior nasal cavity, the middle and superior meatus and turbinates, spheno, spheno, spheno. I wonder if that's a okay. Sphenoethmoid recess. That is correct. Sinusotomy and fluoroscopy do not code bundled items separately. Use modifier 52 if all areas are not examined or if a repeat procedure is not planned. Use modifier 53 to repeat procedure if the repeat procedure is performed. So we don't really have anything that's applicable, but I will say that bilateral and unilateral is, and that's going to determine our answer. So we do have a bilateral endoscopic exam. And if we go to 31225, that's the parent, and this is a maxillectomy with orbital extenuation en bloc. 31230, this did not happen because there's no mention. These keywords aren't even here. No removal of the maxilla, no removal. And this orbital extenuation, that's removal of your eye and all of the tissue around it. That didn't happen. We just had a bilateral endoscopic exam, and then these, and that's basically it. So we had a bilateral exam. We didn't have that. That's way too much. So we're going to get rid of 31230. Oh, sorry. Sorry about that. All right, I think that is wrong. But anyway, we're going to go to 31231. This is your nasal endoscopy, diagnostic, unilateral or bilateral, separate procedure. I love this one. This is indeed a good answer. This actually describes what happened, right? Yeah. A is wrong because it's appending modifier 50. And we don't need to append modifier 50 because it's included in the language, unilateral or bilateral. So that's why A is wrong. Sorry about the on click. Now the 31233 nasal and sinus endoscopy diagnostic. This is with maxillary sinuscopy. There's no mention of the maxillary sinuses, so I'm going to have to say no. And this is via inferior meatus or canine fossa puncture. No mention. So if it didn't happen, we don't code it. And our answer is D. A lot of you said it's A or D, but I want you to pay attention to this unilateral or bilateral. If it's inclusive in the code language, you do not use modifier 50, and that's throughout CPT. If it's in the language, do not code it. All right, so the answer is D. You all did an amazing job. Outstanding, outstanding. Thank you so much for staying. I'm just going to close it out and just let you know what we've discussed. We provided supplemental instruction on the musculoskeletal and respiratory system, a brief overview of the anatomy and physiology of musculoskeletal and respiratory system. We instructed on how to highlight those key terms in those sections, and we practiced coding scenarios to strengthen your knowledge, and we practiced Chun, and we did a little case study.
And we're finished with week 11. Now it's time to discuss the homework. If this is your first time, remember you can get the homework from our website, www.amcicoding.com. Click on YouTube course. Then scroll down, read everything. If it's your first time, read everything. Scroll down and click on the syllabus. And if you see, as you're reading, you'll see that you can sign up for this YouTube course. And we do send you reminders. So click on that syllabus and scroll down to the current week. This is week 11. But if you stop at the beginning of the syllabus, it shows you all of the required texts. And then, if this is your first time, you shouldn't be scrolling down to week 11. You should be starting with week 1, right? Okay, so for the people that have been studying, you scroll down to week 11, and here are your assignments. Go ahead and download the PowerPoint handout from Discord for week 11. You can find it in Discord, and you can find it under resource, file, or handouts. Next, go ahead and watch the playback if you need to. Many people say, hey, I didn't get that. I want to redo. Well, you may redo as often as you wish. So go ahead, click on that green button. Then, number 3, we have a reading assignment. Unit 3, Chapter 15. That's Carol Buck's Step by Step Musculoskeletal System. Then, when you're finished reading, if you have the MCG manual, you'll need to watch the musculoskeletal system. There is a Chun lecture on the musculoskeletal system. So you'll log on, or you'll just go grab your MCG manual, log on. Then you'll click on your charts, video, exams, and additional resources. Just click on that from your table of contents, and it's like the first or second line. All right. Click on it and you'll see the advanced CPT instruction. That's what we call it, musculoskeletal, and there are chun examples there. So go check it out if you have it. It is optional, so it's not required, but it's more if you need it. Then it's time for you to do your thing. You need to chun your musculoskeletal section, right? So if you are a gold or platinum member in the Discord, we have the instructor's chun for you. If you are not, we have the Facebook group. Yes, so you can check out what the students have done. Just join the Facebook group. Team, please give them the link to the Facebook group, and it's on this corresponding slide. Also, it is on your syllabus too. Okay? So, when you get in order to find the chun, you click media, this media button at the top of the page. Then you click albums, and then you'll see all of them, chapter by chapter. And these are really great examples. After you've chun, now you're ready to take your quiz in your MCG manual. Same thing, you click on that charts, video, exams, and additional resources tab, and you'll see all of your quizzes and take the musculoskeletal system quiz. Next, number 7. Yeah, we got a lot this week, right? Watch. We have an additional or an optional lecture for you to watch if you want to. If you need more musculoskeletal system, go ahead and watch it. All right? Learn how to code an operative report, parts 1 and 2. That's if you need more. If you want more, we got more. And now it's time to focus on respiratory system number 8. Go ahead and read Unit 3, Chapter 16, Buck's Step-by-Step Respiratory System. Then you're going to go ahead and watch that lecture that from the MCG manual in its 30,000 series respiratory system. Then go ahead and chun the respiratory section. Make sure you join the chun group. And if you're a gold or platinum member, look at the instructor's chun. All right. Then go ahead and take your respiratory system quiz from your MCG manual. And then don't forget to attend Friday Night Live. Indeed. Yes, go to attend Friday Night Live. And finally, if you just find you don't have time to sit down and watch these lectures or anything, listen to them. We have some podcasts. Yeah. So the podcast link is on your syllabus. Go check it out. And yeah, we do have respiratory, we do have musculoskeletal, integumentary, and I think we have them all. Yeah. Or they're coming. All right. So now we finished musculoskeletal respiratory system. Next time we're going to discuss cardiovascular and digestive systems. So get ready. Okay, coders. And we just want to thank you in advance for completing the survey. Team, please place the survey link in the chat. And coders, if you liked this presentation, please let us know. Give us a thumbs up. If you didn't care too much for it, thumbs down. We need to know. And I don't want to leave here without saying thank you, thank you, thank you to the amazing AMCI team. You are the best. And I liked this message from last time, but I want to say it again. Don't be afraid to fail. Be afraid not to try. Come on, coders. You can and you will. And don't forget to go study, go practice, and go be great. And we will see you in the next session.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI. AMCI.